Good evening, ladies and gentlemen. I would like to finish this evening with a presentation from Scotland, where I work, and I would like to give you a close eye view of telemedicine and the technology that we've been using in Scotland for the past 10 years. I'm Dr. Fiona Mair. I work in the emergency department at Aberdeen Royal Infirmary, and I come from the most northerly islands in the United Kingdom, the Shetland Islands, where we also deliver telemedicine to. This is the hospital aerial view of the hospital in Aberdeen, and I have highlighted this is the accident and emergency department where I actually work. My main interests are, in fact, telemedicine. We've been delivering this type of medicine for just over 10 years now in Scotland. But I have other areas of interest as well, pre-hospital trauma and teleeducation, because obviously it is very important for the doctors and nurses and paramedics working in the remote parts of Scotland and the United Kingdom to be able to access education and new evidence on methods of care for different diseases. The presentation I'm going to give actually involves real pictures of patients. No. Can they hear me? Yeah. Real pictures of patients, so I hope this is not upsetting for any of the audience. Diogo informed me it would all be okay. And of course, the main purpose of my job is to deal with real-life emergencies and very, very sick and unwell patients. So, Scotland is a very small country, but a very widespread geographical area. We have a population of just over 5 million, which is a little bit more than Lisbon, but certainly not anything like what you have in Portugal itself. The telemedicine network now reaches out to most of the remote islands within Scotland and to most centralised, large level 1 trauma centres and even the district general and community hospitals. This is our community setup actually in Grampian itself. We have 15 community hospitals which are led by nurses and nurse practitioners. There's usually no doctors at these sites, and they all feed into Aberdeen, which is the main centre for health. The population within Grampian itself is just over 500,000, which I believe is just a little bit less than the city of Lisbon. So telemedicine is delivered on a daily basis. It's available for all of the community hospitals and the remote islands every day. Usually between the hours of 9 and 5 are review appointments, but any new emergency appointments can be called for at any time of the day, and they will be seen by a senior physician in the department. This is just a picture of the remote community hospital, so you can see the doctor sitting on the little black television screen, and the nurse at the remote end is examining the patient on behalf of the doctor. We started the pilot in 1999, and I was a junior doctor in the department at that time, so I have been involved since its inception. And you can see these are the numbers of patients being seen each month by telemedicine in the Aberdeen Emergency Department, and the numbers have gone up exponentially. So we see new patients every day, and we review many of these patients, so they do not have to travel to the major centre. This is reducing their carbon footprint. They are seen by a senior doctor. They don't have to wait very long to be seen because there is a dedicated doctor to the service every day. We also deliver telemedicine to the police training college because there's no physicians nearby, and we've just recently started a project delivering medicine and care to the prisons in Scotland, as again it is very difficult for them to access health care. We see a variety of types of presentations, and these are the pictures that may, I hope, not upset anybody. So simple injuries, we can see the injury itself, and then we can see the x-ray. So this is a dislocated elbow, which we can then talk the nursing staff at the remote end how to relocate this joint. Soft tissue injuries of the ankles, but on X-ray there is actually a fracture of the bone. And again, this is managed in the community, so the image is taken, the patient is seen in the community, the plaster is applied in the community, and the patient never has to travel to the major centre for their care. And they are then reviewed regularly, X-rays are taken if required regularly, and their plaster is removed at the appropriate time in the community hospitals. Simple dislocations of fingers, a dog bite to a hand, all of these things can be managed. A fairly complex wound, and when things become more, requiring more care, then what we tend to do is they may be seen initially by telemedicine, but they may have to transfer to a centre of excellence for more specialist care. Children we see, and as much of this conference has been about the elderly, the children enjoy being seen by telemedicine. They're very used to interacting with televisions, and they find it quite amusing that the doctor is there speaking to them by the television. The elderly also enjoy the concept of telemedicine because it means they don't have to travel far from their homes. They're seen by the doctor, and they don't find the concept particularly alien. More serious injuries. Again, if the nurse practitioners at the remote end are not sure what to do, these injuries would be transferred. This is a serious head injury, and the patient is transferred to the appropriate centre for ongoing care. And again, we can give them advice on what to do with injured limbs, how to splint them, what types of analgesia to give the patients. In Scotland, we have the North Sea oil industry, and it started in the 70s, so over the past 30 years, the population that work in the oil industry have also aged with the industry. So we now have links to the oil industry, either by email or by video conferencing. We did a project with our Italian colleagues, which won an Innovation in Health Award, where we provided remote care by satellite technology to the oil rigs. ECGs can be sent through this system. The burden on health disease, as already indicated by some of the earlier speakers today, heart disease is one of the biggest killers in the Western world. This is a picture of an arthrotic thrombus within somebody's coronary vessel, which is just about to break off and go further down the vessel till it can't get any further, depreciating oxygen supply to the heart muscle and ensuing a heart attack, if not death. This is tracing of the same person's heart, showing that they are actually having a heart attack. And then we can advise the people on the oil rig installation vessel what they need to do about that. The immediate medicine that is required can be given there and then, so there is no delay in trying to abort this heart attack. This is just a schematic picture of what goes on in the oil rig. Somebody is taken unwell. Colleagues find them. They take them down to the sick bay. The medic on the sick bay connects through to the video conference centre in Aberdeen. I can see the patient, I can see their ultrasound scan, I can see their ECG, and I can advise the offshore medic what they need to do for that patient there and then, so that time is very critical for the muscle of the heart, and they can manage these patients appropriately. The government have put targets onto us now in the United Kingdom. The first one came out in 2005, telling us that we had to deliver healthcare in better ways, and that ideally the healthcare should be delivered nearer to the patient's homes rather than the patient travel any long distance. Scotland has a very remote geography, and patients live very long way away from centres of excellence. A further report in 2007 said we had to deliver better care and better health to patients, and that we had to start preventing rather than curing health. So the government invoked a no smoking policy in public areas, and we are now looking at the long-term effects of those simple policies. And managing long-term conditions, and of course for the elderly that is very important. So Alzheimer's, diabetes, epilepsy, chronic lung diseases from industrial and smoking-related illnesses. Our emergency department sees over 68,000 new adults per year and over 30,000 review adults per year. And in the children's department, we're a combined adults and children's department. We have 18,000 new children presentations per year, and we see over 5,000 children at review. Telemedicine helps reduce those numbers so that these people don't have to wait longer in the emergency department. And that's a big win with the government. But of course, we have the remote locations, which is more difficult to recruit and retain doctors in. And we have difficulties for people getting across cities, particularly in peak traffic times. So we set up an acceptability study in 2005, asking the public of Scotland what they thought about telemedicine. Would they like it? Would they like more of it? Were they aware of the concept? We then looked at the use of diagnostic tools and what works and what doesn't work. Along with the Scottish Centre for Telehealth, which is government funded, they gave us £5 million to use over the first 3 years of our pilot, looking at the ways of applying telemedicine throughout Scotland. We have been working in partnership with Cisco and ourselves as physicians in the emergency department at Aberdeen Royal Infirmary. And Health Presence, which has already been shown on many occasions today, is used. We did a pilot looking at the efficacy and the safety of the equipment, the video conference part, the diagnostic tools, and we've now gone into the clinical application. And to date, we've seen over 200 patients by this method using the Health Presence. This is a concept of how the telepresence booth might look, and if we prove that the clinical concept is acceptable and usable to the public, these booths will be placed throughout the remote parts of Scotland. Other applications that we have teleneurology, where the patients can stay on their remote islands. They can access the appropriate clinical consultants who can stay almost in their own hospitals or at a centre of excellence. So this is just showing that the patient is being examined by a trained auxiliary, and the consultant can sit in their own environment and watch what's being done and interpret it appropriately. Ear, nose and throat complaints are multiple, particularly on the islands, and the consultant can stay in the hospital in Aberdeen. He can guide the remote practitioners on using the teleendoscopy, and he can see immediately what is going on for these patients and diagnose any serious diseases and advise for these patients to be transferred. The majority hopefully don't have anything serious and can stay on their remote islands. Wow, that was quick. Stroke is another concept that we're using. So this is a very debilitating disease and one that we need medicine for very quickly to try and abort the stroke. And again, the consultant can sit in a remote setting, see the patient directly, look at the scan of their brain and decide if it's a stroke that can be given an appropriate medicine for. The remote settings, children are feel very separated from their parents if they have to travel to hospital, and video conferencing is used regularly to let the children speak to their own siblings or to other members of their families. And then when they're happy, they can get back to playing and doing whatever it was they were doing before they became unwell. So pediatrics are using tele-video conferencing a lot, particularly to access specialist pediatricians in Scotland. They're mainly based in Glasgow and Edinburgh, so for the rest of Scotland they can see the children directly from the community hospital or the district general hospital where they are. Many challenges we face, and many have been brought to light today here at this presentations. It's just the tip of the iceberg. We have been delivering telemedicine in Grampian for 10 years now. We have seen over 12,000 patients this way successfully. It could be done globally, as the first speaker today, Carlota Perez, indicated. So it's just a case of thinking how we can apply this and how we can bring everything together. I'd like to thank the APDC for inviting me to come here and speak to you all today and to visit the beautiful city of Lisbon. Thank you.